Good afternoon, and just early address to the afternoon session. I'm going to speak on algorithmic approach as is the trend for all the things today as given by T.D. Yadav. We are talking of gallbladder cancer. We have realized that there are so many problems with it. Cholangiocarcinoma or bile duct cancer poses different kind of problems. And I think in this, the strategy or approach to these patients is also very specific and different, and we need to understand this, that what are the issues which determine the approach to these, so that at least if you have that clear, you are able to make a decision that X patient needs this form of preparation and this form of surgery. And that is what I'll try to do in the next couple of minutes. So you have three scenarios of bile duct stricture, 1, 2 and 3. And our effort is to see what is the diagnosis. We saw some interesting cases presented yesterday, unusual cases of bile duct obstruction. So here, when you do more or other investigations, you find there is a mass lesion and it's a cholangiocarcinoma intrahepatic which is leading on to a stricture. You have a small tumor in the neck of the gallbladder which is causing this tumor in the common hepatic duct, obstruction in the common hepatic duct, or it is the typical bile duct cancer which we are discussing today, which can lead to a Hilar stricture. And we realize that the approach, as we have been discussing, to each of these is different, and therefore it is important to know what is the primary diagnosis which is leading to obstruction at the hilum. I'm not going into further details of this, that what it entails to differentiate between this, but just to say that it is important and we need to make all efforts, and we'll come to some of this while during the discussion. So in this discussion, what I want to show is how anatomy in this region, and based on that, what evaluation we need to do. How do you classify and assess resectability? Once you do that, the term now is liver optimization. That how do you optimize the liver to bear the brunt of major resection? And then what resection strategy, what are the results, and what eventually is the outline for this approach. So briefly, if you look at the anatomy, this is the hilar plate, cystic plate, various liver segments which have been depicted here. And if you look more closely, you know that all these are put together in a small place in a sheath or Glisonian sheath which goes in, along with the three key elements of the bile duct, the portal vein and the artery. You also have the perineural or neural structures, lymphatics, and all this which make it a very critical area with ease of spread from one structure to another, being easily accessible to the tumor. And we need to realize that because surgery in this is determined by extension of tumor to any or all of these structures. So if you look at the hilum closely, you find that the bile duct, the portal vein, artery are there, and then the various segments may have to swerve around the vascular structures, and that has a bearing on the extent of resection and type of resection which we undertake in these patients. So anatomy in this area is very critical, and assessment of the involvement of various structures is the key in defining whether the tumor is resectable and what kind of procedure has to be performed. Going more into it, so you have this hilar anatomy. You understand that the length of the extrahepatic bile duct is there, and therefore majority of times if you want to get clearance, you know that right hepatectomy or an extended right hepatectomy will provide clearance to hilar tumor. Another important thing is the biliary anomalies. The anomalous union of the right anterior and posterior to the left and main common hepatic duct also determines the extent of liver resection. And the location of the tumor, the anomalous union determines what kind of resection you do. I'll show you some examples of that. And it's very important that we pay attention to that, because that changes the mindset in terms of whether it is right, left, or right trisection or left trisection. Another important thing in cholangiocarcinoma, because it is hilar cholangiocarcinoma, the caudate lobe ducts opens there. The excision or the involvement of caudate lobe is critical. And in 90% of situations, caudate lobe would be involved. And therefore, addressing caudate lobe is also a key factor in treatment strategy. I talked about vessels, the hepatic artery and portal vein. And the third element is the pathology of this tumor, whether it is a nodular serous tumor or a papillary tumor, because the mode of spread of this tumor along the bile duct is also different. So if you have a serous tumor, the longitudinal extension is mainly submucosal and it spreads along the bile duct wall. And usually it is seen that it spread up to about 10 millimeter or 1 centimeter. If it's a papillary or nodular mass forming, the spread is more, and you need to give credence for that in terms of how much bile duct you will resect to get the margin. I talked about tangential spread, perineural and vascular, and of course the lymphatics, the lymph nodal involvement. Lymph node dissection, as we saw in gallbladder cancer, is also a prerequisite for treatment of cholangiocarcinoma, and it is also an important prognostic factor in terms of outcome. So once we understand that what are the issues regarding management of cholangiocarcinoma, hilar cholangiocarcinoma, now you see how you can assess and get information about all these things. And imaging is important. Multi-detector CT scan, MRI and MRCP, this is combined with contrast. Direct cholangiography, because the extent of bile duct spread is important. And then you have these other modalities like intraductal ultrasound, cholangioscopy by spyglass, brush cytology, and biopsy. Now, imaging in this is again the key factor which tells you and gives most of the information. And in that, a CT scan is conventionally and for all evaluation purposes is the key investigation, with an accuracy about 90%, and as far as resectability is concerned, again up to 90% accuracy. If you have a problem with respect to lymph nodes and extent of nodal involvement, the sensitivity and specificity of vascular involvement is up to 90%. The lymph nodal involvement is low. It can also give you information about ductal spread by looking at the enhancement pattern. If you have a good CT scan, the enhancement pattern of the wall will give you information about that. And then you have vascular involvement, lymph nodal metastasis, distant metastasis, and metastasis to the lymph node. Apart from the disease involvement, we also need to know that if this much liver is to be removed, that is right liver or an extended right, the remnant liver is equally important now. And whether that is adequate for good functioning. And this is a new dimension in our understanding of how we treat hilar cholangiocarcinomas, that we have started paying attention to the remnant liver, and we need to ensure that that is good enough. So here is one case on coronal reconstruction, right duct, left duct, and a hilar tumor here which is enhancing. You can see it is abutting and maybe involving the right branch. Here in this picture you can see that right branch of portal vein is involved. So you can get all this information on this. Another lesion, lesion here in the hilum, and in the arterial phase you can see there is irregularity of the vessel, suggesting that the right branch is involved. The right branch of portal vein may also be involved, and there are a lot of collaterals around here, again suggesting that there is vascular involvement in this, and the extent of resection is clearly determined by this, and to some extent the prognosis is made. Another case in which you can see that there is a significant hypertrophy of the left side, and the right lobe is atrophic, and there is right portal vein involvement on this reconstruction. So vascular involvement with atrophy and hypertrophy. Then you will see other findings, like if you have metastasis, lymph nodal disease, again suggesting that this tumor is too advanced, for resectional surgery. There's another interesting case. So this patient had had a cholecystectomy, and he had a clip on the right abnormal right posterior duct, and that lobe was completely atrophic. And in the right anterior and left duct, which was functioning, and for the last 5 years he was doing well, he started having jaundice, and we found that there was an enhancing lesion which was blocking this also. Now we had a Hilar tumor which had developed, apart from the clip which was causing atrophy of the right posterior ductal segment. So again, in this patient, new pathology which developed in a patient who had had a cholecystectomy and a combined problem with this. MR scan is useful to determine the biliary anatomy and the extent of tumor in the bile ducts. And I'll just mention the Bismuth type later, but just to show Bismuth type 1, you can see that here is the obstruction of this with the confluence being patent. So MR gives you good information. Type 2 with Hilar, right and left being separated. Type 3, which is extension into the right side. You can see, appreciate this on MR, the right anterior and posterior ductal extension. Type 4, which is or type 3B, which is extension on the right side, and then type 4 with bilateral extension. So this information you can get in a nice manner on MR-CP, and if you do a MR angiogram or a contrast MR, you will get the rest of the information by that. So one of these is good enough to determine the resectability. Then the other part, another important thing is about the atrophy, hypertrophy in Hilar cholangiocarcinoma, and it could be either due to bile duct obstruction or vascular or combined. So this is the typical picture of a right lobe atrophy, a Hilar tumor, and left hypertrophy. And this patient is actually a good risk patient if it is resectable and does not have spread, because the side you are removing is atrophic. You can do a good job and have a good liver which is remnant with a good anastomosis. I was talking about biliary anomaly, and here you need to pay attention to the right anterior and right posterior duct. Now, right posterior duct has a peculiar disposition. It may have a north type of right posterior duct or a southern type of right posterior duct. The northern type, it swings around the right branch of portal vein and joins either the right hepatic duct or the left hepatic duct. So this, what it does is it compromises our ability to take a margin on this because it is swinging over the right portal vein. And you need to understand this, whether this is the kind of anatomy you have or this kind, wherein you can get a margin much more easily. So this anomaly is important to understand. Let's see, look at some of the examples. Let's suppose the anomalous junction is joining on the left hepatic duct, and there is a tumor blocking here. As you can see, I've picked up this from a very nice article, radiological article on Hilar cholangiocarcinoma. And what it does now is, the right posterior and the left ducts, they are all shrunken, and what you see of the liver hypertrophic is the right anterior segment. And this patient will have a very complex resection in that it will need a right posterior segment resection, the left resection, and then a reconstruction of the right anterior segment. And you need to understand this so as to be able to plan your surgery. Another kind of, if it's a regular right posterior is opening lower down, and this is the confluence, and there is a tumor here, and this is spared, you will get a hypertrophy of the right posterior, atrophy of the right anterior and the left, and then here it is straightforward, like we saw that MR, that it's an atrophic segment which you have to remove, and it's already achieved hypertrophy right posterior, and you can do left trisectionectomy in this. Sometimes you can have much weirder anatomies, like in this, that the segment 4 duct is opening here, and the tumor is here, which is involving left and right. Only the segment 4 is spared, and those segments are ducts are liver segments are atrophic, and only segment 4 is hypertrophic, and you need to undertake a complex resectional procedure in this. So the point to highlight is when you're looking at this, the biliary anomalies have to be paid attention, and you need to make an assessment based on that. As we talked about the various types of tumors, and you see that these papillary and nodular mainly superficial tumor extension, whereas the flat one or scirrhus has a submucosal tumor. So you need to evaluate it in different ways in order to see the extent of spread, and it could entail even doing a cholangioscopy and intraductal ultrasound if these facilities are available to you. So briefly we have talked on the evaluation. You put them in one of these, and this helps you determine what kind of resection you are going to do. Sometimes we realize, and people have realized, this is not good enough. And from Memorial Sloan Kettering, Lupcard has come out with a classification which is T1, T2 and T3. Basically what it says is either confluence involvement, that is T1, right or left with extension. T2 is atrophy with or without ipsilateral vascular involvement. And T3 is either involvement with atrophy either of the opposite side or vascular involvement of the opposite side, meaning it is unresectable. And this one correlates with resectability being poor in T3, margin negativity to get poor in this, and more often having distant metastasis. So it's a good predictor if you have this kind of a classification, what to expect in this patient. So if it is significant major liver disease, medical comorbidities, T3 type, extensive nodal involvement, and distant metastasis for sure are criteria of unresectability. Some of these may be borderline. Once you know that, then you start optimizing. Maybe I need to go a little faster. Let's see. The first thing is about whether to do pre-operative biliary drainage. Once you know that you have to do a major resection, and these are the benefits and risks of it, we all know. The question is which patients we should choose to do biliary drainage. So what is recommended is, routinely it is not recommended. It should be done if your future liver remnant is small. Some say 30%, others say 40%. If patients have symptoms, you have to do. And if the future liver remnant is small, then in order to get that up to mark, then you may have to do. The other issues about pre-op biliary drainage is percutaneous transhepatic, endoscopic or endoscopic nasobiliary. And there is a lot of controversy which is coming about. The standard one acceptable is percutaneous transhepatic, but lot of Eastern literature is coming on ENBD because they feel that assessment by nasobiliary catheter with cholangiograms is better, and you can keep these patients on ENBD without the problems of stent getting blocked. You can flush this, and they have shown that ENBD is better, but it's a problem of managing ENBD for a period when you need biliary drainage and the patient having the tube sticking out of it. The other issue is whether total versus selective, means you do bilateral drainage or one-sided. The recommended is whichever lobe you are going to retain, you drain that to achieve best function, and total you only do if there is still persisting cholangitis after drainage of one side or jaundice doesn't resolve. What is the optimal duration of drainage? Again, the best, now it has been found that less than 2 weeks is good enough, or a target bilirubin less than 3 mg or up to 3 mg%. More than 2 weeks has no benefit in reducing complications. But sometimes they may need longer drainage if there is persisting infection or bilirubin is still high and you do not want to take extended resections. This study from Memorial Sloan Kettering showed that if you have a future liver remnant of less than 30%, then if you drain the future liver remnant, then the operative mortality and hepatic insufficiency is low. If you don't drain, hepatic insufficiency is 33% and high mortality. If it is more than 30%, then there is no difference in outcome whether you drain or do not drain. This is a systematic review. Again, it shows that there is no difference overall, but the pre-op biliary drainage patients fare worse in terms of morbidity and infectious complications. The second part about about liver optimization is augmentation of the residual or future liver remnant. And there are various recommendations, but in this is the kind of review of more than 3,000 patients, and basic indication has been shown that if the future liver remnant is less than 40% of the total liver volume of that patient, then this patient needs augmentation. Both the normal and diseased liver hypertrophy, that is to understand that, and it may need to be done for 4 to 8 weeks. If the degree of hypertrophy pre-op of that segment compared to post-procedure is less than 5%, then it is associated with poor liver outcome and post-operative liver failure. So this is how it looks: pre-op, pre-procedure, post-procedure, after embolization. And these are the results. So you can see that with a period of 4 to 6 weeks, just say 2 or 3 minutes more, the hypertrophy is up to 20% in 2 to 8 weeks, and atrophy of the ipsilateral lobe, and the outcome is good with low mortality and low hepatic insufficiency, which is our aim in doing that. Just a word about caudate lobe. So when you have a Hilar cholangiocarcinoma, the caudate lobe is invariably involved, as I said. And it is now well shown that when you do a caudate lobe resection, the margin positivity is, say, at least in this report, is around 30%. The recurrence rate is 51%. But if the caudate lobe is preserved, then the margin negative positive rate is much higher, with much higher recurrence rate. Another observation, again, when resection, high disease-free survival compared to when caudate lobe is preserved. So it is a well-established fact now that caudate lobe resection has to be done. Vascular resection, it can be done when it has to be done, but in a systematic review again of 13 studies, it was associated, basically it is a marker of advanced disease, and it was associated with lower curative resection rate and poorer overall survival. But it can be done, it is feasible, it can be done with acceptable morbidity and mortality. So what we try to achieve, we are trying to achieve this kind of results. That resection rate of around 70%, you may need to do vascular resections, a mortality of 2%, morbidity of 43 or so, around about that, with a 5-year survival in RO resection of more than 50%. And this is also seen by other Asian experience. This is from Assad, a 5-year survival of 47%. So what is the algorithm which we have? You have a Hilar block. It is not absolutely essential, as we discussed, in a clinical scenario to have a histopathological diagnosis, because it is difficult to get, and majority of times it is a Hilar cholangiocarcinoma. Resectability by the means which we discussed about is the key determinant of taking a decision what to do further. And once you take that decision, you have to optimize the patient to get to a situation where your surgery will provide good early outcomes in terms of morbidity and liver failure. And no doubt, if this is good, the long-term outcome is going to be good. And your strategy should be, if it is a type 1 extrahepatic bile duct resection alone, these are very few and far now in current this thing. Type 2, you may do a parenchyma preserving resection. I think we have a talk on that. Type 3A, right hepatectomy with caudate lobe resection. If you have extension into the segment 4, then you have to do a trisegmentectomy, and you need to look at augmentation of the future liver remnant. Type 3B, again left hepatectomy, and if it is going on to the segmental branch, left trisegmentectomy. Thank you very much.
And
you want to take questions, because I think discussion.
Because you are leaving, we can take the questions. And thanks a lot for such a wonderful coverage of the topic. And I think we can take up 1 or 2 questions, then we can discuss for the lunch. Because sir has to leave, so we will discuss for the lunch after this. Or we can, because we have many presentations for Hilar cholangiocarcinoma. Any question at this particular stage? Yes, Dr. Vikas, please.
Hilar cholangiocarcinoma patient with maybe bilirubin more than 15 or 20, they also need to be taken because you are planning a major liver resection like right trisec, and you may need liver augmentation subsequently.
Yeah, I mean definitely that's what I said, that pre-op biliary drainage is required. The only caveat I would add is sometimes what we have seen, and now we are seeing a couple of patients like this, that they have a bilirubin which is high, but they have atrophy of the, say for a right, I showed you that patient, that patient had a bilirubin of 12 or 12.8, something like that. The right lobe was atrophic, right portal vein was involved. We thought it is good enough to go ahead and resect this patient and do a right appendectomy because the future liver remnant is good and you can achieve that without introducing any risk of, because infectious complications after drainage is there and you need to balance that out. But I understand that in any situation, if there is an adequate liver which we are going to remove and it is a substantial liver and the bilirubin is high, most people would agree that some form of liver drainage has to be done, preferable of the future liver remnant, and for a period it comes down, say at least below 5.
And what is your cutoff level at which you will be comfortable resecting without drainage? At what level of bilirubin?
See, again, there are two parts of it. One is bilirubin, but apart from that, what is the patient's status? What is the future liver remnant? And is there any other comorbidity, nutritional status, sepsis? All these will go into it. So I don't think bilirubin per se would be. But I would be prepared to resect a right appendectomy with adequate future liver remnant, even say up to 10 mg%. And so I think that's okay. But I think you need to take the full picture into account, not just one bilirubin.
Yeah, that is, I mean, bilirubin question only comes if other factors are controlled.
Yes.
That is the only question. Yeah, but the thing is, at times we have also seen, like operating upon these cholestatic livers, they bleed very badly. And is there any trick to decrease bleeding? And do you routinely prefer to put a portal clamp in these patients while you are transecting?
Yeah, I mean, I don't know, but I don't think there is any specific this thing. It is just a little bulky thing to transect through, so you take a much longer time in this cholestatic big lesion. I think if you do meticulously, very lately I've started using for this ablative surgeries, radiofrequency bipolar, radiofrequency this thing, and it works quite well. I thought it's a very good, it is a modification of the Habib's probe. This is a bipolar this thing, and it works quite well, and you can do a resection with very minimal blood loss. And here you are seeing that it is a ablative procedure. It is not that, and I think it is now well proved that portal clamping, even in patients with obstructive jaundice, is well tolerated, and the same thing, the maneuver which we do for 5 perfusion, 5 minutes perfusion and 15 clamping should be good enough, that cycle, to do that. So you can use it if it's bleeding.
Despite, goes without saying that it was a wonderful, concise, explanation of the Hilar pathology. Sir, ENBD, it's a wonderful modality despite its discouragement by the medical gastroenterologists. As surgeons, so many times we need it. Especially, so I wonder, twice what we've done is that placing an ENBD, generally it has only a tip, which is a very few holes are there in the tip. So what it does is completely diverts the bile out through the nose. Having an ENBD, twice we had to puncture holes, so that what it did was, it internalized this thing, we just capped the ENBD, it was more patient friendly. So whenever there was a doubt of it being blocked, just put in a guide wire and just open it up. So that takes away the discomfort of the ENBD and also internalizes the bile, this thing.
I think that's a good idea. I think it's a good suggestion. My only thing, I was recently there in Japan and I was talking to them because they are really switching over to ENBD, this thing, some of the centers. I was saying that, to keep these patients for 2 weeks or 3 weeks with a tube, they manage it in hospital, but we can't do it and our patients won't take it. But there is some merit in it, but I think the final word is not said on whether this way or that way, and you need to really look at it. But I think it's a good idea that you simultaneously internalize and you avoid the blockage of it. Yeah.
So what are your tricks for achieving left lateral segment hypertrophy with right portal vein embolization?
No, I think, again, the anatomy has to be studied. And I know that we have, in instances, 2 instances I remember clearly, that we have the recovering branch of portal vein, we have embolized to ensure that the left segment 4 doesn't get hypertrophied if you just do the right. So there are no tricks. I think the point is that if you really feel that left lateral is small and you need only hypertrophy of left lateral, then you need to ensure that the segment 4 branch is also embolized. And you obviously, you all have good interventional radiology. You obviously need good interventional radiology to ensure that segment 4 is also embolized at that time. Yeah, I think I'll just quote one instance. Just last month I was in Japan and I had the opportunity to meet Dr. Makuchi. I was sitting and talking with him, and somehow out of the blue he made this statement that so much is being talked about Alps, it's bunkus, he said, and it's just brouhaha made about something. But anyway, that was his opinion. The available evidence in cholangiocarcinoma on Alps, there are 1 or 2 papers, and it is very bad outcome because the septic complications are very high in cholangiocarcinoma, where you are probably draining also in such situations, or even if you don't drain, this cholestatic liver to leave behind like that. So most of the people, recent articles which I have read about Alps say that this is not a good option in cholangiocarcinoma. It's good for liver tumors and metastatic liver disease, but not for cholangiocarcinoma.
If I think there is no further query. If there are queries, we have a whole session for Hilar cholangiocarcinoma. Thank you once again, sir, for a wonderful discussion.
So can I just take 2 minutes, since I may not be able to address you? I can say that thank you very much, Dr. Yadav, and the Department of Surgery of PGI Chandigarh to host it and take up the midterm CME. I think it's been just a wonderfully organized meeting, and not because how well you've organized, but because you've just got such good delegates, and there's been so much of enthusiasm outside that we notice in terms of discussion, and whatever discussions we have had on the podium across it have been very nice, educative, and I think from our side on behalf of IHPBA, I can just say that it's been a wonderful meeting which has been organized, and we are very thankful for the department to do that. Thank you very much.
Thank you, sir.
The first prize is a check money of rupees 5,000, and the second prize is a check money of rupees 3,000. This is given on behalf of the IHPBA and the organizing committee. To announce the results, I would like to request Professor S.P. Kaushik to please come on the stage.
Well, it gave me great pleasure to announce the prize winners for this competition. The second prize first goes to Srinivas Banod. For the poster presentation of correlation of fibroscan with liver biopsy in benign biliary stitches. Vijay Ganesan and for the poster early versus delay cholecystectomy in mild acute pancreatitis. Where are you from? Both of you from PGI or institution?
I'm from IGMC.
Come this time. Just since you have called me here, just give me a minute before you start the session. I'd like to be excused so that I could go now and leave the session. And before going, I would like to thank all of you, particularly TD. Well, little I say about it is better, but this young man has really done me proud. And that's the pleasure of teaching, as I said yesterday. Thank you all of you, his residents and everybody here has done wonderfully well, and it has been a very nice conference. Thank you very much.
We will now start our third session on Hilar Cholangiocarcinoma. I request the chairpersons to kindly take their seats on the stage. First, I would like to invite Dr. Shastri, Head of GI Surgery, KIMS Hyderabad, Dr. T.D. Yadav, Organizing Secretary of the CME.
First talk in this session is by Professor Park, Planning of Surgical Resections and Hilar Cholangiocarcinoma. When to do what? Professor Park. Professor Park is already been introduced. He is the branch head division of Translational and Clinical Research, National Cancer Center, Korea.
Chairman, for your kind introduction. I'm Park from S.J. Park from Korea, National Cancer Center. You know that in Korea, National Cancer Center is only one. Maybe Japan, several National Cancer Center there. China is also in Korea. Only one National Cancer Center. So, from Delhi to Korea, nearly 5,000 kilometers. I'm sorry, please.
Rajesh?
Can I use this, please? I'm working. And also, National Cancer Center is located 20 kilometers from Seoul, northwest area. And you can see that there is a boundary between South and North Korea, so you can feel very close. And this is my institute, National Cancer Center, is located very beside a beautiful forest. It is composed of hospital, research institute, graduate school of medicine, and also National Cancer Control Institute. So I'd like to show you the evolution of surgery for Hilar Cholangiocarcinoma to show, as you see, in the 70s, the mortality was up to 20%, and 5-year survival was around 10%. Recently, mortality reported to be less than 10%, and the 5-year survival is up to 40%. So, to be like this, several good things have actively influenced. I think that is PTBD from 60s. Paraben embolization first started 1986, and the incidence of major liver resection increased. And also endoscopic stenting or major biliary stenting started. And also these days, very aggressive combined resection to achieve R0 resection should contribute this kind of advance. So to be shortly speaking, the aim of the surgery is to achieve R0 with R0 with safety. Professor Maguchi reported with previous vertical studies that the rate of major hepatectomy was closely related to the rate of curative resection. And also, he pointed out that the studies of the patient with the portal vein embolization show low rate of liver failure. And also, 5 years ago, we met this very shocking reports from Nagoya. They reported simultaneous resection of portal vein and hepatic artery for Hilar cholangiocarcinoma, and the 5 years survival rate of a patient with simultaneous artery vein resection was 30%, and the patient without any vascular resection was 47%. So actually, I was so shocked. Who am I? So anyway, much improved. So let's back to today's issue, surgical planning for cholangiocarcinoma. Actually, Professor Shikora told us too many things so well. So many things are similar with me. So I try to skip the common things. So first, we should assess operability. It's very important. So I try to stress the screening of nutrition status. So if the patient is malnourished, you should consider the preoperative nutrition support for this patient. Next thing is, of course, very important, resectability assessment. For this, two kinds of things you should consider: tumor extent and future liver remnant. To assess the tumor extent, most important thing is, as you know, CT and MRI with MRCP, and sometimes PET. And for future liver remnant, to enhance function of LR, PVD, pre-operability drainage is important. And to increase volume, portal vein embolization is these days essential. You already heard that these two processes are called optimization of liver. I will not deal with ERCP, PTC, or PTCS. Of course, these are all valuable tools. However, for cholangiography only, I will say later, but MRCP is better than these studies. And to get FNA or growth cytology, many institutes has abandoned the kind of process because the sensitivity rate was so long, and to do cholangioscope percutaneously, it has too high rate of tumor seeding. So I think the routine pathology is not routinely recommended. So for nutrition, in the ESPN, the European Society of Parenteral Enteral Nutrition, and also ASPEN, American Society, recommended that for these patients, like body weight loss more than 10% for 6 months, or BMI less than 18.5, SGA means subjective global assessment, nutritional screening tool. Grade 3 means severely malnourished, and the serum albumin less than 3 should have a preoperative nutritional support. So the duration is, as you know, at least 7 to 10 days. And the second issue is to assess the tumor extent. To do this, CT and MRI is critical. Before that, you should know about bile duct anatomy. Many of these things already you know. A transverse portion of left IST exists usually 97%, and it is usually long, between 1 to 5 centimeters. So, if we consider, for example, classic type 2, which segment, which side, right or left hepatectomy is more better if we consider that. Many experts recommend that right side hepatectomy because it guarantees long resection margin and easy to anastomosis of bile duct, and also sometimes portal vein anastomosis easy. But the big point is the future liver remnant could be small. This is very useful paper from Chiba University, Professor Miyazaki group. Yeah. Maybe this idea already Professor Shikola has told us. Yeah. This is the relation between light IHT and portal vein. If the light IHT, especially light posterior bile duct, is going up through the portal vein, it is called supraportal type. If the light posterior bile duct goes beneath the portal vein, it is called infraportal type. As you see, infraportal type, you can get the more long resection margin easily. So after resection, the specimen like this. So usually it's supraportal type, but if we met infraportal type, you can get the bile duct resection margin more. So before surgery, you can think about it. So previously you heard about that, but if classic tumor, two spread. First is longitudinal through ISD and the vertical superior and inferior through liver or vascular structure. So you can see that hilar mass is very close to light hepatic. So even disease type 1 or 2 bile duct cancer can invade right hepatic artery. That's why that is one reason why we do right hepatectomy for type 1 or 2. It is very genius work from Professor Sakamoto that usually mucosal spread goes up to 20 millimeter, usually in papillary type. And some mucosal infiltration, usually nodular or infiltrated type, goes up to 10 millimeters. So you think about it when you decide the resection margin. Cancer cell can go more than we think. This paper is also very valuable from Nagoya group. From gross margin, microscopic invasive cancer can go 10 millimeter. And non-invasive cancer cell, this means carcinoma in situ or highly dysplastic cells, can go up to 20 millimeter. So for CT and MRI, it's most important to assess normal anatomy, tumor spread, and resectability. Especially CT, valuable for volumetry, essential for surgery for cholangiocarcinoma, and MRI for cholangiocarcinoma. I'd like to introduce our liver volumetry program. the name is Dr. Liver, which is invented in my institute with other institute help. So we adapted it from last year. So just we extract the CT image easily from PACS system. And you can put the point in the liver in the multiple, in several cut. You can just put the point. And the program can extract the liver, whole liver. And after some addition, needed. And then you can extract the exact whole liver. And then you can make a vascular structure like this. That's putting the point. And then with a big ball, you can make a resection margin with a curved line. So like this. This is a famous patient for liver transplant in donor. Anyway, very shortly you can get the liver volume. It takes about 5 to 10 minutes. Also, with this program, you can image the segment-oriented liver resection. You can just put the segment you want to reset here, like this, and the liver suddenly reset. And the remnant vascular picture and the remnant liver can be seen clearly. So this program we invented last year, and you know that many other volumetric probe is so expensive, but this is not so expensive. And then move to the cholangiography. For just the cholangiography, which is better, the MRCP or the traditional PTC or ERCP? Of course, with PTC, well, yes, we can get a very good imaging. But these days, as I told you, MRCP is the choice because MRCP is getting better and better. Like this, and we can get a 3-dimensional image. So MRCP is better because it is really non-invasive. It can show whole bile duct structure and no cholangitis. And with the actual coronal image, you can assess the vessel, the liver invasion, or intramedullary. Anyway, you can get many information. So I think MRCP is a choice for cholangiography. PET is sometimes used, and still there are valuable things. I'm not sure, but the papers from Korea that with the additional use of PET-CT, you can change the 15% of resectability. So now I move to the future liver remnant, the function and volume. So PVD and PVE, so-called optimization. One thing you should remember is PVD should be performed after studies of resectability. It's very important because if we do PVD before study CT, like you can assess the tumor extent because of the tube. So, if possible, always do study first and then PVD. So, many of you knows about this paradigm shift. Anyway, Nagoya University is, I think, #1 for this field. And even 2005, they told that most patients with Hilar cholangiocarcinoma should have PTBD. And the PTBD to all occluded branch, multiple PTBD, and PTCS is essential. However, 3 years later, PTBD, ENBD, ERBD, everything okay. And the unilateral, they recommend. And 2 years later, very important paper, EMBD is recommended, first recommended, because of the track seeding. So also I was so confused. At last, PTBD was defeated and the era of EMBD comes. So I will briefly introduce 3 issues. Is routine PTBD necessary, and what is choice of PBD and unilateral or bilateral? So as you know, PBD has some good things and also has bad things. If you see, the disadvantage of PBD is like this. It takes 2 weeks for normalization of your function. And also PBD increase infectious complication, and also most bad thing is tract seeding, and also cause periductal fibrosis. So when we do operation, we can discriminate inflammation with the cancer. So this is paper from Memorial Sloan Kettering, 1999. They really, for a long time, they insisted that PTBD is not good. So preoperative period stenting is not good because of the infectious complications. However, the situation is different. Most institutes do routine PBD whenever jaundice positive or eye dilation, until a little bit less than 2 or 3 milligrams. But this does not have any strong evidence. Recently, very interesting papers from Europe, multi-center study. You can see that 180 liver resection, major resection, OP mortality was 10.5%. Very interesting result. PBD versus OP mortality, no relation with overall mortality. However, for right side hepatectomy, PBD induced reduced mortality. However, left side hepatectomy, the mortality was increased. Why? Left side hepatectomy, infectious complication related mortality was high. And also, bilirubin around 3 milligram is a risk factor only for right side. That means we should think right side hepatectomy, left side differently. I think it is very important message, and I agree with you with this. So, still in debate, and I don't think that EMBD is best. In fact, I am doing PTBD first. So, still, I'm not sure. And which route is choice? You know that several things, PTBD, EMBD, and EM, several things have its own advantage and disadvantage. Maybe you know about that. And as I told you, 2010, we have reported that PTBD tract recurrence was at that result 5.2%, quite high. So the risk factor was long PTBD interval and multiple PTBD and popularity. So when the patient with the PTBD tract recurrence showed poor survival. So with this result, they concluded that EMBD is first. So I checked my institute result. For 10 years, we did 156 classic tumor resection, and also surprisingly, we had also the 5% of PTBD tract seeding. And succeedingly from Japan, in the title, ENBD is the most suitable preoperative biliary drainage method. They concluded like this. However, attacks from another side comes from them. This is a multi-center study of Netherlands and Memorial Sloan Kettering. They compared PTBD versus the endoscopic biliary drainage, and they found that there was no track sealing. So they think track sealing does not matter. And this is from papers of Korea, Assam Medical Center, 171 PTB. Track sealing 1.7%. So we concluded that there is no definite ability to avoid PTB whenever it is indicated. So still the debate is still ongoing. So we need really good randomized control trial to solve this problem. So 2015 multi-center trial, the name is drainage trial, preoperative endoscopic versus percutaneous transhepatic drainage in potentially resectable perihilar carcinoma. They compared these two routes so we can get very valuable results several years later. Lastly, unilateral pilot, you know this one. Now, we know that unilateral is sufficient. So, last year, in the review article, I will read. I promise. Preoperative biliary drainage, right lobectomy for business type 3A or 4 hilar cholangiocarcinoma is indicated. Preoperative portal vein embolization and chemoradiation therapy indicated. Biliary infection or undrained bile or severe pleuritis. And instead of selective, the indication for total biliary drainage is development of cholangitis after selective drainage, slow resolution of hyperbilirubinemia, and opacification of bile duct. So you should think about that. The last issue is portal vein embolization. It started from 1986. There's no randomized control trial about this clinical deficiency. However, I think it's maybe impossible now because it is already critical for patients. Indication, you should remember two things, volume and function. Normal liver, less than 20%. Moderate liver, less than 30%. So I think that for hilar cholangiocarcinoma, future liver remnant less than 30% or 40% could be indicated. And this figure shows the interval between portal vein embolization and surgery in terms of future liver remnant hypertrophy. You can see that after 2 weeks or 3 weeks, the growth rate is decreasing. So you don't have to wait too much until 2 or 3 weeks is sufficient. So degree of hypertrophy, this is a result from Nagoya. That is the last one. Future liver remnant hypertrophy degree was in average 133%. So also outcome from Nagoya's result, so many Nagoya's results, however, 494 patients, no portal vein embolization related mortality, and no serious, seldom serious complication, and OP mortality was limited. I'd like to show you some interesting papers, 2 or 3. This is a concurrent biliary drainage and the portal vein embolization. You can understand, concurrent. So they did 6 patients. It was reported in 2013, maybe. 2015. Concomitant PBD plus PVE. So future liver remnant growth was quite good, but cholangitis developed in 3 patients. So it could be a problem, but it is very interesting idea. And second is, you know that in low bile duct obstruction, like pancreatitis now no routine biliary drainage. However, recently metal stent introduced. So metal stent has some advantage compared to plastic stent. They do not have stent-related failure and complications. So they introduced metal stent to Hilar cholangiocarcinoma in UK. So they did 10 patients with a self-expanded metal stent, and the procedure success rate was 10%. No stent failure, so it would be one issue in this field. I will show you one case. This patient, 50-year-old male. We did 4 PTB because his bilirubin was so high and the decreasing rate was so slow. So you can see that this patient is type 4 because B2 and B3 were separated. So our plan was a resection like this, like trisectionectomy, and if we do, we can get the resection margin clearly. And with the volumetry, his future remnant liver of lateral section was 19%. So we did right side oral embolization, and his future liver remnant became bigger to 28%. The degree of hypertrophy was over 150%, 150. So we did right trisectionectomy, and you can see the mapping of the right side. You can see the mapping of the cancer cells, and we can get the free resection margin. So it's good these days. And the liver grows. So our last slide. Thank you, everybody. The aim of operation for Hilar cholangiocarcinoma is, as you know, zero relapse safety. So I would like to really, talk about the preoperative nutrition support. I think cholangiography, CT and MR plus MRCP should be performed before biliary drainage. Biopsy or breast cytology, my thinking is not routinely recommended. PVD indication, right side routine considered, left side question. Root still ENVD versus PTVD. And unilateral PVD is usually sufficient. For indication of Caudate embolization, for Hilar cholangiocarcinoma, FLR less than 30 to 40% may be indication. So I went to, yesterday I went to very beautiful places of the city with my new friends. So also maybe rock garden, and a very beautiful lake. I went there. So thank you for your attention.
Thank you, Dr. Paul.